BW Healthcare World. My name is Harbinder Narula and I welcome you on this World Heart Day. This theme for this year urges us to deliberate action, to influence policies, to advocate behavioral changes as well as physical activity. And everyone can be an influencer to bring this change. I'm privileged to have with me today Dr. Ashok Seth, who is someone who's performed 50,000 angiograms and over 20,000 angioplasties, for which his name has been included in the Limca Book of Records. He is a recipient of the Order of the Isabella of Catholic Honor and has also been awarded Padma Shri and Padma Bhushan by the Government of India. He was the cardiologist to perform the first angioscopy and directional atherectomy in the region. He is also someone who's been reported to use the first impeller heart support device and drug-eluting stents, biocerebral stents and thrombectomy devices in India. Let's speak to Dr. Ashok Seth. Welcome Dr. Seth to BW Healthcare World. It is a pleasure to have you taking our time for our viewers.
Thank you very much, Arvinder. It's a pleasure to be with Business World and with yourself discussing around heart disease.
Thank you so much, sir. Dr. Seth, before I deep dive into my questions, I want to understand one thing. You've done a lot of firsts and much ahead in your career. What gave you the courage to take these steps, to do these things as the first person to act on these for the people in India?
It's a very fascinating history. I was trained and I was well trained, and I also believed as I came from abroad that the reason for coming back was delivering back to the country. Right. And many of the techniques and technologies did not exist in the country, and certainly the expertise was sparse. Right. And if Indians needed to benefit from it, then I had to believe firstly in the technique. And angioplasty at that time was nascent. Many of the techniques were just coming out, and they were only prevalent in the West, and yet our Indians are devoid of it. So I said, if I've got to deliver it to India, and if I've been trained abroad, then it falls on me not just to bring those techniques to India, but also make sure that I then teach it further and teach it to many other interventional cardiologists or youngsters, so that we can be the masters of the technique and patients can be offered that. So conviction on the technique, but also conviction on myself and the belief why I was doing it. So it was not a cowboyish effort, it was a principled effort to say, this is my focus, India is my focus. I could have stayed abroad, I was there for 10 years, but if I came back, then I had to deliver to the country and to the people of the country. What is very fascinating is that these techniques, which are only done in the West, and many of them were the first, not just for India, for Asia Pacific, I then not just taught India how to do those techniques, I actually went across Asia Pacific to countries like Indonesia, Malaysia, China in the early 90s, in the early and late 90s, Bangladesh. Oh, I have trained 50 interventional cardiologists right here with me as fellows each for 1 year. Who from Bangladesh. So that was the start of interventional cardio in Bangladesh. Nepal, my fellows exist in Nepal. And then of course further down, it was up to Singapore, Malaysia, and some of the centers in Australia on some of those techniques, because we had them much earlier, and I was a master of them much earlier than the rest of Asia Pacific. So yes, it's been a great journey, but it's been a journey of giving back to the country, of conviction, and of saying, if I'm the one who has the skills, then I've got to make sure that I deliver to the country.
Oh, absolutely, that's brilliant, and gratitude to you for making the difference to the society at large, because you've gone beyond just keeping it to yourself, but you've enabled other doctors to be able to spread that goodness and spread health to other parts of the world as well. Dr. Seth, let me begin this conversation around the World Heart Day with you to understand that we have been seeing a lot of young people succumbing to heart conditions. What has gone amiss? I mean, we've always seen in the past that heart conditions were with people who were post 40 and they would be more prone to this. But now we're seeing young people facing such problems. What has changed?
You immensely, this is one of the most important points of discussion. Yes, over the last 20 years, the heart disease and heart attacks in age less than 50 has risen 200%, 250%. And that's a huge figure. By the way, we are the heart attack capital of the world, but we see heart attacks 10 years younger than the West. And nearly 25% of our patients who have heart attack are less than 40 years, which is a rarity in the West. The reason has been quite clear. Heart disease is multifactorial, and we know that the lifestyle of our young gen has changed immensely. We see that there is more desk work, less of activity. There's incidence of smoking, which is a very bad thing for heart disease, as we know, has gone up. Lifestyles in terms of stress at work, meeting deadlines, competitive, aspirations, all have increased much more. At the same time, obesity, lack of exercise, bad food habits have all increased. This 5 or 6 risk factors have predisposed to even diabetes and hypertension on the increase. And therefore, our youth has been subjected to exactly those very risk factors which we tell everyone to avoid because of the lifestyle. It's just the change in the whole circumstances and lifestyle. But we must also not forget 2 other important risk factors which came through more recently. One is pollution. And pollution has been shown to increase heart disease and heart attacks. And I think in our big cities, there's no question that pollution has increased immensely over the last 20 to 30 years. And you've seen it yourself, the number of vehicles, the number of other factors. And finally, COVID in recent times was known to increase heart attacks by another 100%. And that was well documented. So we had a spectrum of risk factors, and more recently, of course, like I emphasized, pollution and COVID.
Dr. Seth, you mentioned lifestyle, and you also use the word stress. I've seen that stress is more common these days than what we have seen when we were younger. Have you observed that stress becoming the front runner when it comes to the leading cause for heart conditions among the young of the patients who are coming to you? And what do you think should be done in the society at large to control this?
Yeah, you're right about the stress, but I also want to emphasize 2 other important points if you're going to prevent heart attacks in the young. And we've seen those unfortunate visuals of young people exercising or bodybuilding, etc., suddenly collapse from a heart attack. Smoking is a bad risk factor, and nobody should be smoking. That I have to emphasize right now because it has to be conveyed to the viewers. Even sitting with smokers and having smokers as friends makes you smoke a cigarette a day if you're actually spending time with friends, even if you're not smoking. So it's as bad as that. And then we talk about the food habits. Fast foods are on the increase. Eating out is on the increase. Many of the stuff that we don't see, which tastes good, actually has huge amount of trans fats in it, and we never look at that. And we only look at the taste. So that's another. And of course, obesity and the fact that less of exercise is happening is an important risk factor. And when I say exercise, I want to again emphasize to the viewers, gymming and bodybuilding is not a heart healthy exercise. It makes you look good, it is physique, and there's nothing wrong with building muscles. But heart healthy exercise actually means walking 40 minutes a day, brisk walk 40 minutes a day, 5 times a week. It's as simple as that. All you need is a park and 2 kids.
Yes.
And with that, can you believe that we can decrease the chances of heart attack by 25%?
Wow.
And that's what's not realized, because it takes care of high blood pressure, it takes care of diabetes, it actually takes care of weight, it takes care of cholesterol, it brings down the cholesterol, it makes us feel better, feel less stressed, and it brings every factor under control just walking briskly. So if we walk more than 40 minutes, by the way, we are just increasing our stamina. We're not necessarily being heart healthy. If we walk an hour and a half, we probably lose weight, but not necessarily being heart healthy. But if we gym and body build, that's another exercise, which is aerobic exercise rather than anaerobic exercise, and that is more meant for physique, etc. And that's why if someone says, oh, I'm going gymming, I say, it's good, but it's not necessarily heart healthy. Right. It's not necessarily heart healthy. Coming to the stress issue, yes, stress in life has gone up. There's no question. And that's because of the competitive world we live in, the aspirational and inspirational world we live in, and the deadlines have grown. And even at workplaces or in our own homes, there's a lot more stress, even, whether it's a family, whether it's children, whether it's their studies, whether it's their career, everybody's. But on the other hand, doesn't everybody have stress of some sort or the other? I have certain stresses, you may have different stresses, and we are being stressed in some way or the other. More important is how you absorb that stress. All of us have stresses. It may be just that the driver did not come and how do I get to work, versus a sick patient, or you may have another deadline to meet and you're actually under stress. So how do we absorb it? And the best way to absorb, I found it, of course, is that there are three aspects to it, of course. Take enough time off work. We got into a stage where we think work is everything and it's a worship, and we pride ourselves by saying that we work till 11 o'clock at night, we work at 12 o'clock at night. And the other one says, well, I work throughout the night. But we don't take time off work. We think that's sacrilegious. No, more time off work, spend it with the family, spend it with friends, have a laugh, take up a hobby, learn music, do things that you enjoy. That's why in the West, while there's a 5-day working week, which is norm, they're moving to even a 4-day working week, which is the right balance of life. But we have never seen that right balances of life. So that's one aspect. The other aspect is yoga and meditation. It's perfect way to relieve the tension, the stress, and everything else. Oh, pets are another one to relieve stress. Going out on a family holiday with this, even painting with your family is a great stress reliever. But another big stress reliever is spirituality. I think we've been missing out as science has progressed immensely over the last century. We've been enamored by science. We've started believing that we become gods in some way. Remember, I mean, medical science has grown, but even from the first flight in 1904 to landing on the moon, and 1904, when Oral Brothers took off with a Kitty Hawk at Kitty Hawk for the first flight, 120 feet. Man landed on the moon in 1969. It just took 55 years for man to land. And it's just so fascinating that insulin came out in 1942, and we're now conquering every aspect of heart, whether it's heart disease, whether it's any tumors, etc. So we've been enamored by science, and more recently, we've of course given up spirituality for what we see. I'm glad, in a way, while COVID was bad, it actually put humankind in its place. Yes. A small virus told us that we, as every medical scientist's brain, could not stop the whole world, stopped in its track for 2 years. So what did it tell us? It told us that that's the time when we started praying. When everything was happening around us, we started praying. We said, God, please save us. So spirituality, so if we want to live in this century, we lived the last century in science, and we gave up. Humanity started believing it was a God. Yes. Now, if we got to move further, science and spirituality have to combine together and move together. Then we start living in the world. Otherwise, we were living on Earth.
It's so true, Dr. Seth, because I keep talking about that. For things to work in your life, when everything is well and when nothing is going well, when you have a health condition, so you have to go to God and have faith in God, and then you have to go to a doctor and have faith in the doctor, because unless you believe that the doctor can heal you, your body will not react. And the body not reacting is not just the medical phenomenon. I believe there is more spirituality in that. So I like to kind of differentiate between trust and having faith.
And can I just add on to that?
Yes.
And go to the doctor and have faith in the doctor, and I say the doctor should have faith in God.
Absolutely.
Because it's very, sometimes I think through this a lot. I say I do so many complex procedures. In fact, anybody who fails or can't be done, they do come to me and say, we believe that you can do it. And I say, and I leave home saying, God, please make sure everything goes right. And then when I go back and I've done the procedure and everything has gone, I say, God, thank you that it all went fine. Yes. The reason is that this is a human body which is very complex. We only understand it as if we stand in 2024, which is better than what we had in 1994.
Yes.
And what we knew in 1994 is now obsolete. Those techniques are obsolete. And even when I look back and say I was doing those techniques, that was the best at that time, but now they look so outdated, that they look so crude, that I wonder how I was treating patients with those techniques. Right. Go another 30 years and what I do today will be looking outdated and in many ways weird.
Absolutely. Absolutely.
And it's just like the cell phone and our first phones, and then when we didn't even have a phone. So it's almost that anything can go wrong at any time. I may do the same thing for 200 times and everything goes right. And then in one patient, the same thing, which is exactly done the same manner, doesn't go right, because that's how his body responded. So I say, God, please make sure that every patient does go fine. So yeah, they say,
no, it's really important, because you have to have somebody that you have faith in,
yes,
who guides you to do the right thing.
Absolutely, absolutely, and always puts the blessings on you.
Absolutely.
And
sorry, please go ahead.
No, I was just going to address the trust aspect that you
yes,
had. Yes, there is, I would say, a decay and a loss on trust on doctors in general. Mm-hmm. And it's not, I wouldn't say it's fault of doctors or the public. Well, there are multiple reasons for that. Mm-hmm. It's not necessarily because the doctor is unethical. No, I don't think. It's a rarity that a doctor would be so unethical as to harm the patient. Mm-hmm. It's, in my mind, that doesn't even register or happen.
Correct.
It is a perception. And in a materialistic world, where more and more private medicine has been often discussed as a business, right, that this wasn't the case 20 years ago, 30 years ago. Even a practitioner wasn't a businessman.
Correct.
He was your caretaker, he was your guide, he was your mentor, he was children from the time they were born, and the parents were always the patients and bonded. Of course, we live in a different world, which is much more materialistic, and therefore there's a mistrust, there's a suspicion. And medical science is so complex that if things don't go wrong, we ourselves don't understand the human body. We can't even create a hair, we can't create a skin, we don't even know how our mouth is working at such a speed, which even no robot that we've created can ever speak like this. Right. And yet we are expected to heal that completely and have a cure for it. Now, the second aspect is, so that's the public, and there's enough on Google, etc., which is truly misconceptions and can never be absorbed accurately enough. On the other hand, the doctors have become busier and busier, especially in the public hospitals. The infrastructure may not be exactly the same, and I'm now going, as doctors in general, infrastructure may not be adequate enough. There's too many patients, doctors have less time, they're overworked, they're practically working hours and hours. So there's a discrepancy between explanation, connection. And if you have no time to connect, वो कहते थे ना कि पेशेंट आता है तो कहता है कि आप तो बात करने से ही आधा ठीक हो गया।
बिल्कुल बिल्कुल।
और आपने नहीं बात की तो वो ठीक भी नहीं हुआ, बट वो मिसट्रस्ट में चला गया। सो हमें पेशेंट के साथ बात करना, एज अ डॉक्टर आई फील कम्युनिकेशन, एम्पैथी, केयर, कॉम्पिटेंस is so important, and of course conscience, ethics. अगर ये हम 4 C's patient को दे रहे हैं ना, he will never have mistrust. Absolutely. He will never have mistrust. Absolutely. And that is why I say some of the mistrust is because we're not conveying enough, we're not talking enough, we're not communicating enough. And the other mistrust is, of course, patient is misinformed, too many avenues of incomplete information and expectations in this materialistic world that he needs a cure because he's paying for it, and science, medical science, has still no cure for most of the disorders.
Absolutely. I feel one more thing, sir. I think there is, like you said, there is a lack of complete information, and we are leaving a lot to assumptions. When a patient goes to a government hospital, when he pays something like 5,000 rupees, he assumes that the cost of treatment is 5,000 rupees. And when he goes to a private place where they're charging for the same thing 50,000 rupees, he doesn't understand why are they charging 50,000 rupees. Nobody is talking about the cost of treatment. Even in a government hospital, it is not 5,000 rupees. It's what you are paying, but somebody else is filling up for that 45,000 rupees. So I think there's a lack of complete information which empowers them to make an informed choice.
Absolutely. And because majority of our patients have to pay out of their pockets for the treatment, it actually therefore is more so to do with, yes, expense versus expectations. And I would say both sides have to deliver. The trust has to be cemented. And I think both sides have a responsibility towards that trust, because I don't believe any doctor is there to harm a patient. Every doctor is there to do his best for the patient, even though the perceptions may be different. And we need to really repair those, should we say.
Absolutely. Coming back to the heart health, we were talking about anxiety, we were talking about spirituality. The youngsters of today, they seem to be more anxious, and probably because they're so used to getting everything at a click of their button. If they're feeling hungry at night, they are not waiting for somebody to cook food for them. They can order it on Blinkit and other places. My son, if he has something which he forgot to tell me but needs for the next day at school, he says, Papa, Blinkit kar do. But when things go wrong, they're not able to manage their anxiety. In heart health, we are talking of golden hour. If you are able to give treatment to the patient in that 1 hour, which is very critical, you can save a life. When things go wrong in a corporate environment where there are a lot of people working, there are bound to be situations where they need medical help, or somebody at home. People are not aware as to what should they be doing to act in that golden hour. What is your suggestion?
So I think, you touched on multiple points which I would like to clear and emphasize. I do believe, and I'm glad that I'm saying this to business world, because your communication with a lot of business leaders is profound.
Correct.
And I believe it's a responsibility of every business to keep everyone's heart healthy and safe. And let me expand on that. What's the theme of this World Heart Day? Use heart for action.
Correct.
What does that mean? That business leader who runs a big office or a big company or a big factory can do so much of action. Now here's a list I can give you. Firstly, let's not even get to a heart attack, but let's get to how he can keep heart healthy. Those canteens are there where samosas and pakoras are served. I see, why shouldn't there be a gym where that 15 minutes can be used for exercise, or an exercise machine or something like that for if it's an office. If it's a bigger area, why shouldn't he have a playground or something where people are able to actually in that half an hour be able to have some form of a sports and encourage people to be a part of that sport, even if it's just brisk walking in the middle of your break.
Correct.
There's also the issue around people have heart attacks. Each person in your own factory can save another one when he collapses.
Yes.
How many factories, how many people, how many offices have trained their personnel on basic life support, which is practically nothing? Basic life support is just laying a person down who's collapsed and pressing his chest 100 times a minute till an ambulance arrives. And that can keep the person alive. How many people have just taught that? No one. The fact that we actually do not take this into account is so important. How many big offices and factories have an external defibrillator, AED, which should be there practically at every big place or every busy place? could save lives. We still don't want to save lives. We just say it's somebody else's. How many offices will have an aspirin tablet that if a person had chest pain, the treatment of that is Disprin tablet and you just chew it? How many offices with that? Simple stuff. So I think this call for action is important. I want everyone, right from the head of a family, to head of a company, to factory, to policymakers, to regulators, to sit and every individual sit there. What can I just do for my heart, but what can I do for all others who are influenced? Can I save their hearts also?
Correct.
And simple methodologies, which I just said, can save that. For myself, I would just say, why am I not exercising by just going up and down the stairs for 10 minutes? In a break between people, we all go down and have some form of, say, let's have a cup of chai, and uske saath biscuit. Those biscuits have trans fats, or say, let's have a samosa, or let's have a pakora. And that happens pretty much 2 or 3 times a day in offices. शाम वाली चाय आ गई और उसके साथ पकौड़े नहीं आए या कचौड़ी खा गई. And yet that could be 5 times up and down those 4-5 flights of stairs instead of using the lift, and you're done with your exercise and you're done with that preventing heart attacks. So that's the first part. The second aspect you asked was, so what happens if somebody has a chest pain and this is a heart attack? What is this golden hour about? So understanding that this is a heart attack is important. A lot of people just mistake this ki thodi si jalan hui, acidity hui, gas lagi, chalo abhi to nahi, Diagene manga lo, kha lete hain, sham ko dekh lenge, and by the time it doesn't go away, a few hours have passed by, and by the time they come, the heart attack's been 12 hours. But the symptom of heart attack can be acidity in 20% of the people, or feel like acidity, unusual acidity, ki kuch kha liya tha uski wajah se, but actually it's a very uncomfortable feeling in the chest, severe, associated with sweating, going down the arm. It's like a discomfort which has not happened before. So to those who think it's acidity, I'd say, if you're prone to acidity, take a Diagene. If it doesn't get relief in 15 minutes, start believing you got something wrong. But if you haven't had acidity and you get this discomfort which sounds acidity, think that it's a heart problem, get an ECG done as fast as possible. So the issue becomes, if it's a heart attack and it's documented, the thing is not sorbitol under the tongue, which everybody thinks, should I take a sorbitol because kisi dost ke paas hoti hai, family ke paas padi hoti hai. That's a bad thing because that can drop the blood pressure. What is most important is aspirin tablet. And that Disprin is the one which is soluble aspirin, which dissolves the fastest. So just chew a tablet of Disprin. The moment you chew it, it starts acting against the clot within 10 to 15 minutes. It's instantaneous, within 5 to 10 minutes. And then rush to the first hospital, the closest one, the closest big hospital. Because 2 things can happen in that golden hour. There's a proportion, a small proportion, who will suddenly have a cardiac arrest and die from a heart attack. Okay. So that's one of the reasons to rush to the hospital. The second is the faster heart attacks happen because the artery gets blocked. It's 100% blocked. The faster it gets to the hospital, the treatment for opening up that blocked artery, which is usually an angioplasty, and the best treatment is putting a stent in. Correct. If the hospital has that facility, it'll do it straight away. And nobody should actually mistrust the hospital at that time because log sochte hain ki ji abhi to theek tha, heart attack hua, keh rahe ki stent dalna hai. No, this is the golden time to save your heart muscle. That's what does it the best. Of course, where facilities are not there of doing an angiogram and angioplasty at the same time, they're pretty powerful clot dissolving drugs, and that's good. So the golden hour is a time when someone can actually crash and die, and that happens in 2-3% of heart attacks, and the remaining have the ability to get to a hospital, have a treatment, and prevent damage to their heart. So I think it's a very important question, but I think the messaging is also important. Get to the hospital as fast as possible. Absolutely. And when we talk about all this, I do believe that even friends, relatives around need to understand how to save lives. And that we'll get to that, I mean, I couldn't tell you right now, but we can also talk about it.
This is really important because that's where they don't know. I mean, they're panicked and they don't take an action because they don't know what to do. They're like typically spending time to call up someone कि इनको कुछ हो गया है, क्या करूं?
You and again, because we are addressing a lot of business leaders today, we are addressing today a lot of public through this tremendous platform that you have. I want to say this, that aren't those disturbing, and I again say this to your viewers, those disturbing visuals of our great singer who was in a hotel lobby and he just collapsed, or even in a gym. Those lives could have been saved. Why didn't those gyms have AEDs? They're just those simple paddles. The machine tells you what to do, and we've seen those AEDs. Luckily our airports have it. But why don't those places have it? But I'm saying, why isn't the person who was photographing all this could have saved that life?
Could have saved that life.
It doesn't take much of a training to save that life. That person should have saved the life rather than photograph it. And what does that take? I think I want to say this on this because for me, saving lives, a bystander saving life in those collapse situations is the only way that person's life is going to be saved. It's been shown Seattle is one of those cities where every resident of the city has been trained on what we call basic life support or basic resuscitation technique. Can you believe that all the heart attacks which happen, and I've just said that people collapse and die, that small proportion of heart attacks will collapse and die, it could call it sudden death. They are able to save 75% of those sudden deaths. Actually, the possibility of saving them is pretty much zero if you don't do anything.
Correct.
It's death.
Yes.
And they're still able to save 75% of the lives there of out of hospital cardiac arrest. The reason is everybody's trained. And what's the training? All you do, and I will therefore emphasize it today because it's also just not important for the public. It's also important for every relative of every heart patient, because that collapse and sudden cardiac arrest can happen to anybody at any time, either from a heart attack or pre-existing heart condition. So what do? If a person collapses in front of you and really falls to the ground, the first thing you actually look at him is make sure that he's flat on the floor. Flat on the floor is when you see and assess whether he's breathing or not breathing by bringing your face close to or watching his chest for only 10 to 15 to 20 seconds. At the same time, you call for a help and ask your colleague to call for an ambulance. While you're watching this, and in 20-30 seconds, if you don't see a breath and you're shaking the person and saying, "Are you okay?" and there is no response for 30 seconds, start compressing the chest. Center of the chest, 2 fingers, make sure he's on a hard surface, which is the floor. Just kneel on his side and compress the center, right here, the center of the chest. There's the breastbone. Compress that so it goes down by an inch. And compress that 100 times a minute. So that's what you're doing. Okay. And in the meantime, just make sure that his neck is turned up so that the airway is okay and the tongue is not falling. So somebody just holds his neck slightly straighter so that the tongue is not falling, and you continue that. There is no mouth-to-mouth respiration needed. So don't be figuring out, should I do that? No, all you need is chest compression. And continue the chest compression till the ambulance people arrive. The longer you can keep a patient alive with that for 10 minutes, 15 minutes, and his brain won't suffer, because the first thing which happens out of cardiac arrest is that we may bring the patient, somehow manages and rush to the hospital, but in that time we may bring his heart back, but his brain has suffered the injury because that's the most sensitive organ. Right. And so therefore, this basic life support is well represented. Just go onto the Google and you'll see how easy it is to save lives. And you don't need advanced training. So please go onto the Google, watch what I've said. Basic life support, hands on, just understand there's no mouth-to-mouth resuscitation. It's fully basic life support with your hands only.
I think the message is loud and clear, and I think it is absolutely imperative that, one, in large offices where you have a lot of people, the management shows the responsibility to ensure that the equipment is there and people are trained. Okay. Second is, I think this message needs to be delivered through schools, because children, something that they have learned at a very early age, it is nothing very different from them. It's a part of their life, it's a part of their training, and they will remember it for the rest of their life. I think that's where we need to go.
I also want all offices to put up this basic life support on their walls. I mean, we have all sorts of all sorts
Posters.
of
So
posters.
these are the ones that we need to put.
There are all sorts of posters. Why not have a basic life support poster everywhere? Just 3 steps are there, and everybody just remembers those steps. It's so automatic.
Correct. Dr. Seth, when we are looking at heart condition, and now there's been a lot of study on genomics, etc., where we are studying the genomic makeup of different people living in different parts of the world. Are Indians more prone to a heart condition than other people in the world?
Well, yes, we are. And we'll discuss whether it's genetics or others. But we are 3 times more prone than white Caucasians, Westerners, 6 times more prone than Chinese, and 20 times more prone than Japanese to develop heart disease. That's why India is the biggest capital for heart disease and heart attacks. 20% of the deaths from heart attacks across the world happen in India. Yes, there are certain features amongst us which make us more prone, and that's it's well recognized: high triglycerides, abdominal obesity, glucose intolerance, or tendency for diabetes are all risk factors, and they are called syndrome X, and perhaps it's been passed down the genes. But actually, it's far more confusing than that, because we also have the highest incidence of diabetes and highest incidence of hypertension and highest incidence of cholesterol in the world. So as such, even based on the risk factors, we're much more prone to heart disease. So it's not just genetics alone, because heart disease is multifactorial. Yes, we see these situations where, of course, family history is very important. And if I am an individual where my father or mother had heart attack at an early age, or either one of them died at an early age, and by early age we say age less than 60 in general, then, or my brothers or sisters had a heart attack, then I must start getting checkups by the age of 20. So that's one importance. Family history is a very strong issue. The second aspect, of course, is, as you said, genetics. Cholesterol is also passed down the genes, and that's why we say have checkups. Have checkup for diabetes, which is a silent killer. We won't even know we got diabetes till everything is haywire. Hypertension exists in 1/3 of the adult population, and perhaps in 15 to 20% of the young population. And again, it's a silent killer. And again, that has to be checked. So I think the checkups are far more important, because it's not just the genetic predisposition, it's also our predisposition to those very risk factors which cause heart disease. And those are all silent. Cholesterol is silent, diabetes is often silent, and high blood pressure is always silently discovered. And if it's our responsibility, therefore, to know our risk factors. We say, aap checkup karwao, and you've heard of this fancy thing. Again, we're talking to a lot of business leaders ki kehte ji CT scans and ye or wo or echo, and ye so bade expensive tests. Obviously, who wants to get these expensive tests done? So I'm the proponent of saying all you need is a visit to a GP to know aapka lipids kya hai, cholesterol kya hai, which is a routine blood test. Sugar kitni hai, that's a routine blood test. And BP check kar liya, high blood pressure hai ki nahi. And if you have this, you got 80%, 90% secure. Now, for few people, we may say, acha, an echo. Echo is always a great thing. Zindagi mein ek baar echo ho jana chahiye. It's a very easily available investigation. But you don't need CTs unless there's such a strong family history, or you have certain symptoms where the doctor says, theek ab CT bhi kara lo, because you have these risk factors, and I'm going to treat you so specifically that my treatment is a personalized treatment of lowering your cholesterol. So CT, but actually to know your risk factors is a responsibility which I have. And it's easy, and I'd be able to prevent heart disease in myself if I knew those risk factors.
I think, early screening can actually help you not reach the symptoms or the need for symptoms at all.
Prevention
is the
key for this country.
Absolutely.
Even though we're making huge advancements in science, technology, research, everything, for me, treatment comes after we've emphasized prevention. And progress of treatment, of course, has been very fascinating.
Since you're talking of progress, screening, technology, sir, I remember in 1995, my father had a heart attack and he had to undergo a bypass surgery, and everybody was very fearful about heart conditions. Today, like we were talking that what existed in 1995 is so different than what we are doing today, and probably 30 years later we're going to be laughing at what we did in 2024. Is this taking away the fear of heart treatment and heart condition from people's mind. Is it positively working or is it actually telling them that ठीक है, सब कुछ ठीक है, अब सब ठीक हो जाता है, डरने की जरूरत नहीं है?
No, it's working positively. Right. And I mean, my career 40 years ago, when I started doing cardiology, training in cardiology, can you believe that the treatment of heart attack was put the patient in a CCU and do nothing for a whole month? There was no treatment available apart from put him in a CCU and observe him. And they would actually rest for a month. Now, and then evolved, give that clot dissolving drug, which was very crude at that time, and people would bleed. And still we gave that, and of course we started seeing patients get better, and then we went on to this angioplasty, we went on to stents, and now we save lives. The death rate from 15% from a heart attack has fallen to 3%. Okay, and the treatment has evolved so immensely that in the 30 or 40 years we've seen from a sanatorium to active treatment and stopping heart attacks. The important part of it is that yes, science and technology, expertise has all been patient oriented, saying how can we make it minimally invasive, how can we make it safer, how can we make it more effective, and how can we give lower mortality and better long-term outcomes. And that's why whether it's angioplasty, where earlier in exactly 30 years ago, and we said that was crude treatments 35 years ago, believe you me, the mortality was 2%, rate of heart attacks with that technique and technology, which was still considered robust in those days to the comparator, was still heart attacks on the table would be 5%. Now, can you believe that mortality or risk at angioplasty is less than 0.2% for a death 0.1%? Heart attacks on table are rare at 0.5%, and complexities of patients have gone up, and yet the results are in points, lot less than 1%, and practically in less than 0.5%. The same thing goes for bypass surgery. That's evolved immensely. There are no more those bypass circuits and putting the heart on a bypass. It's all less invasive. It's just stitching the grafts on a beating heart, which has made it safer and less riskier and more effective. So I think everything is moving towards patient focused treatment to give him least risk and maximum benefits, and that's why it's getting less and less invasive also. For example, we're replacing heart valves without surgery in a technique called transcatheter aortic valve implantation. It's TAVI. And aortic valves could only be treated 20 years ago by opening the chest, and still opening the chest, opening the heart, putting the patient on a bypass circuit, cutting the old valve out, stitching a new valve in, closing the heart, stitching the heart back, getting the heart again, pumping again, then closing the chest. So all this, of course, as the technique evolved 20 years ago, and TAVI, and I've been one of the contributors to that and its development, and an introduction into India, and more recently into trials and others, that become the standard of care. So anybody above the age of 60, 65, especially those who are at higher risk of surgery, sometimes even those who may not be at a higher risk of surgery, right up to the age of 100, can just come in the cath lab, put a catheter, 30-minute procedure, put a heart valve there in a conscious patient, just like doing an angioplasty in a conscious patient. You may be 85, you may 90, 95, just half an hour, 1 hour of a procedure, 1 day in hospital, go home the next day, back to a normal life, with a 98% safety, success and safety. I think that's huge. We've gone huge, and I think this science has progressed not because everyone got together, the surgeons, the interventional cardiologists, the imaging specialists, the echocardiographer. The differentiations went away, and everybody said, let's work together. We got these techniques, and I've got expertise in this, I've got expertise in this. How can we get together to do something which is so less invasive for the patient that our patients benefit from our expertise together? And I think that's tremendous way forward in every specialty we see. So if we see things developing, it's only because the doctors broke the bridges, should we say, the divides among themselves, and said, patient comes first, how do we do this?
Dr. Ashok Seth, India is blessed to have an education system where we have produced some of the best doctors in the world, and we also have some of the best engineers that are known. We are seeing a lot of medical advancement today, and we are moving towards AI, etc. What are some of the contributions of India to the world where we've done something which has changed the way healthcare is provided to the world, where we can as a nation take pride of?
A very important question, especially in our sphere. You know, these stents and the stents are the mainstay of treatment of blockages, mainstay of treatment of heart attacks, mainstay of treatment of coronary artery disease. Angioplasty is performed in 75% of the patients who have coronary artery disease. And of the stents being used in the country, earlier everything was imported. Over the last 20 years, we've developed our own stents. And when we developed our own stents, and I was a principal investigator of most of the first studies of all these stents, which are Indian manufactured, have been done by me for approval by our country. And we call them our approval studies. We had conviction, we had faith in our own stents, but the world did not. And I must say that the world did not, because they always tell, ये तो वहीं के लिए बने हैं, वहीं पे यूज़ हो रहे हैं, शायद गरीबों में यूज़ हो रहे हैं, और हम तो नहीं यूज़ कर सकते, because हमें तो trials चाहिए, बड़े-बड़े trials चाहिए. For Indian approval, we need smaller trials, but the West needs blinded, pivotal, randomized, placebo-controlled, state-of-the-art trials. Well, we are proud to say that many of our companies went into the West and did the randomized trials, because they would only get used in the West, all European countries, even some of the Asian countries. United States has, of course, own set of rules, but the rest of the world. And can you believe that these stents got proven non-inferior to the best of the West? Non-inferior to the best of the West, which means the gold standard थे ना, उससे non-inferior, and in some cases even looking better in certain subgroup of patients. That has been a huge eye-opener for the rest of the world. There are Indian stents being used in the West, in England, Italy, Germany, Spain, name it. Indian stents have proliferated there because of the advantages. Not just have they proven in randomized best-in-class trials against the best standards of the world to be as good, but also they're less expensive. Right. And for the third-party payer, it becomes an ideal solution. अच्छे भी हैं और कम सस्ते भी हैं. It's not just happened in the stent field. It's recently happened in the TAVI, the transcatheter heart valve I was talking about, the procedure. See, stents are easier to make. They are, after all, stainless steel, cut out, laser cut. The technology has been around for quite some time. You can copy the technology. But transcatheter heart valves are implants of such nature that they're very complex. They have to be, big things have to be compressed into small catheters. It evolved, and more than 200,000 TAVIs are done across the world. It's proliferating. It's become the treatment of choice beyond the age of 60. So transcatheter heart valves are very complex. Can you believe that India decided to, and one of the companies decided to say, why don't we create one? Because for India, each of those valves, as we started introducing it to the country in 2012, when we were the first to introduce it into the country, and as it got approved and as it got proliferated, these valves were costing us $30,000, the same as in the West. And when the Indian company decided to actually say, why can't we actually make it more affordable for the country and created the valve? Yes, we did the first in-human studies for India, and it proved that it was a good valve. So it came at a cost which was half the price. Okay? And then the same company decided that if really got to do better, then we've got to again do the randomized prospective trial against the best of the valves, which we were importing from outside. So they did the study now in Europe, not in India. They did it in Europe. They told the Europeans, here's the valve, let's now study this, let you do the randomized trial. Can you believe that randomized trial, which was pivotal, stood the best scrutiny of every science, was presented and published in the Lancet this year? Wow. Lancet, the biggest journal. presented at the biggest meeting in Europe, presented at the same time, publication in Lancet, proved that our valve, created and made in India, researched in India, was as good as the best valves which we were importing and implanting it here and across the world, as the contemporary valves, and also in some ways advantageous and better.
And now, half the price.
And yes, and well, whatever they're putting it in the West, they have the right to. But yes, for us in India, it's half the price.
Awesome.
So I think that's a moment of pride. You know, when we obviously all this happens with close collaboration between scientists, researchers of India, made in India, that manufacture in India, and then of course we as doctors have to combine together to advise, to therefore study it, to be able to give it so that the patient has the best, and then we all combine together. Then it's a win-win for the country as a whole. It's not just a win-win for the researcher or the manufacturer, it's a win-win for the medical community. Absolutely. And as a business, believe you me, it is outreaching consequences not just on the prestige of India, but also the amount of foreign exchange it saves, but also amount that we are now exporters of that expensive device for the rest of the world, for every part of the world. That study proved that we can now sell that valve, and every country would actually now approve it, apart from US, which has its own rules around doing a study in United States.
That's so nice. That's brilliant. Dr. Seth, since you're talking of technology and the advancement that we have made as a nation in the field of medical, there were two challenges that come to my mind. One is that while good heart health care is now available in tier 2 also, our rural interior parts of the country are still devoid of this availability of this health care. Yeah. Similarly, if somebody is coming from overseas to get treatment in India and they go back and there's a recurrence of a situation or condition, how are we in India using technology to bridge this gap, to be connected with these patients and to be able to help them? Are there technologies being used? Are there collaborations being done with doctors overseas or local doctors? I was at a round table recently, and the challenge that we were talking of was there were no doctors available in rural parts of the country. And somebody brought up the thing that, listen, while quacks should not be there, but can we train some technicians to be there who can be in touch with the doctor and at least provide the emergency treatment? So what do you have to think about, say about this?
So a lot is already being done in this area, because I am very thankful to Honorable Prime Minister, who's got a real focus on this aspect. So Niti Aayog has a huge focus on this aspect. So does the digital transformation of India has a huge aspect to this. Mm-hmm. In fact, Viksit Bharat has a clear aim that the developed Bharat has a huge health downstream. That's why Honorable Prime Minister did announce that One Earth, that global health.
Correct.
One world,
one
the health part of it at the G20. So the health part is huge, but it's all to do with wellness also. Let's also understand that yes, with digital transformation, there are two aspects come in. Firstly, of course, telecommunication, telemedicine has become a norm, and COVID, in a way, being a bad disease, at least had some silver linings. Correct. Around this aspect of things. The second thing which happened out of the silver lining out of COVID is this uniform mindset of partnerships for single aim. Mm-hmm. Whether it's policymakers, regulators, public sector, private sector, innovators, scientists, manufacturers, legislations, all combined together, every stakeholder, doctors, healthcare workers, and right down to the patients, everybody combined together to deliver one aspect, and which is actually Bharat became Viksit at the time of COVID. Correct. The resilience of Bharat, where the whole world thought that there would be dead bodies scattered around this country, did not happen. In fact, came out that huge Bharat, which was able to create vaccines, to vaccinate a whole of Australia in a single day, yes, and even give it to our friends and neighbors around the country. we exported everything which the world did not have at that time. So I think we are very proud of that, and that needs to continue on. When we talk about transformation, yes, it's going to happen digitally. In fact, we are all, and so is Niti Aayog, looking at the fact that more nurses need to be trained in a manner that they can deliver healthcare at the primary level in continuation with the telemedicine, telecommunication, and with digital. After all, reachability of our web and net is practically all over. Availability of cell phones has gone deep in.
Yes.
And I think those things which actually now make the West look ancient, we have progressed immensely in that. So what's happening now? Yes, we call them physician assistants. The West has physician assistants because they also have they want more availability of health at the patient side. So we're looking at physician assistant, Niti Aayog looking at training more nurses, skill sets, etc., to be able to deliver exactly in that manner. Yes, ECGs, blood tests, blood pressure can all be transmitted and is being transmitted. Many of the public hospitals have linked up smaller hospitals. Many of the district general hospitals have linked up primary health centers to them. Many of these AIMs which have been created across the country have linked up secondary district general hospitals to themselves. Right. Again, through telemedicine and through digital, so be able to educate and train. We've done that ourselves. We have a scheme working called eICU, which we developed 12 years ago, where 760 ICU beds have been linked up into a command room, and one can see blood pressure and heart rate and changes and advice on treatment at every on every patient as a ward round happening virtually through specialists sitting here. That's at our FMRI facility. Mm-hmm. So yes, a lot is happening now. Wearable devices. Mm-hmm. See, all these digital transformations and digital initiatives are empowering the patient to take care of himself. Correct. Looking at prevention more than treatment options. Yes, we need to look at treatment options, but prevention, of course, becomes the key. So wearable devices is one of those aspects where we can monitor our patients. We can also see whether he has heart rhythm problems, what's his blood pressure doing, and even to an extent, and we have these wearable devices which tell us, and we are using them, where a patient who has heart failure and is on treatment and starts developing fluid, which may end him in a hospital as an emergency admission in 2 or 3 days' time if he wasn't noticing it. Mm-hmm. That signal and that beep warns him that there's something wrong happening. He's able to contact us. We're able to up his medication, and it prevents him and gets him better at home, and it prevents him from a potential admission which could have happened. Right. In fact, keeping the patient out and keeping him well has become a major aim of ours rather than have him back into the hospital. In fact, in the West, the quality parameters, and I always keep saying this, there's no reason for a patient in India. I know that we have Ayushman Bharat, which has really served a lot, and I think it's a great service to the nation, and I don't think any nation would be ever to be able to create Ayushman Bharat like we've done. Mm-hmm. The first phase is get as many covered by this scheme, and the second phase is going to say, are they getting the same quality? Correct. As if I was sitting here and treating a patient? Are they getting the same quality? And that's the second phase, because quality means not just a patient getting admitted to the hospital and going home. Quality means that he stays well. Absolutely. And second aspect of quality, which the West has researched on, is, has he got a readmission in that next 6 months? Why did he have a readmission? If we are able to keep him out and there's no readmission, then we know that we did a good job. That's quality care. I hope you
absolutely. I think
if I put a stent in and he had a heart attack and got admitted, for whatever reason, whether it was a bad job I did, whether it was a bad instruments that I did, whether I cut costs for Ayushman Bharat, or whether I cut costs for some which way or the other. But if I did a bad job, and that means the patient had to come back, that's a quality issue for me.
Absolutely.
And I have to be assessed on that. So I'm saying that there's no patient who should not be able to get a treatment down in a district hospital, in a tier 2 town, in a tier 3 town, as good as the one I give him. And he should be out of the hospital and stay out of the hospital. And we have a responsibility towards that.
Absolutely. Dr. Seth, my last question to you before I let you go, I know I have taken a lot of time. is going back to what you were talking of, that if a patient comes or is brought in an emergency and the doctor is needing to do an angiography or needs to put in a stent, and they go back and speak to the family, and the family feels that, listen, he seems all right, it was just a small pain, does he really need that stent, does he really need? So there's a lot of trust issue which is there, and in that turmoil of taking a decision at that point in time, they are confused, right? What is the role of the doctor on duty at that time, as well as the role of the family, so that people build that trust, are able to take an informed decision in the benefit for the patient?
I think it's a very important question that you answered. Are the procedures being done correctly? Are they being based on the guidelines which have been created? Are they going to benefit the patient, and which patients is going to be benefit? Because it's an evolving area. Science and research progresses into deciding who's going to benefit. Does every blocked artery need a stent? Which blocked arteries do need it? Can medication, and by the way, medicines also progress. Tablets and drug therapy has progressed immensely during this time also. So it's not just that stents came in and became the wonder thing. Nobody had ever seen something like this before. At the same time, we've known how drugs have worked and can prevent heart attacks as well. So we have this huge area of science trying to figure out which patients do the best with the advances in drug therapy, which patients do best with advancements of angioplasty and stents and the new devices and new techniques, and which do best with surgery. But the most important moot point is informed decision making. So there are two criteria I always believe. Firstly, so appropriate use criteria. I believe every hospital should understand and have an appropriate use criteria where you tick off certain points to say, this patient, if he needs a stent, is based on these criteria, which are well recognized at the moment, which may evolve over a period of time, but which is a present knowledge and science. And one has to tick those boxes off to say, yes, he did have chest pain, he's got an exercise test which is positive, he complains of a discomfort, and therefore he's on the table because of that. But after that, I don't believe that stenting should be done without on a patient who's on the table by explaining to him on the table alone, apart from those who got such an emergency that if we didn't do it at that time, like a heart attack patient, like one who was having unstable angina, or saving a life where you have to say, let's put a stent in right now, because otherwise even the 15 minutes would be too late.
Right.
Okay? But others, I always believe, unless the patient himself has said earlier that if you find something, please treat it, I don't want to be shifted out,
Right.
those are the only ones you should take. But I have a simple philosophy. I always take the patient out. I leave the tube in to go back in. The patient should be given enough time in his own atmosphere with his relatives to be explained what I found, to be explained why I think the treatment is needed, also to be explained the urgency. And by the way, most cases are not such emergent. Apart from heart attacks and unstable anginas, most patients who come in and have blockages, they came out of walking after all. And they could go home and come back in a week's time if that's what he wanted. So there's no reason for us to scare anybody. There are medications which will hold them for that time.
Right.
Time has to be given. The patient may decide, no, do it today. That's informed decision making. But if he asks me, can I have it done 5 days later? Yes, he could have it done 5 days later.
Right.
So therefore, we have to discuss it. He is to be given time to understand it. He is to be given time to agree. And it's his decision whether he wants it on that day or another day.
Right.
Apart from emergencies, everyone should have the ability to decide with our help.
Yes.
With our help. But certainly, if they needed a second opinion, we should encourage second opinions.
Right.
That's the transparency and that's the trust. If I'm confident that I'm doing the right thing, then I would want to tell him, if you're uncertain, why don't you have another opinion? You can get it done with me 3 days later. I'm still here.
Right.
But there's no rush. So yes, convenience of the patient, he may want it that day. Emergency situations, which can't wait for 24 hours just because it's such a critical blockage and he's been having chest pain that it would be late, inform him, that's why you're doing it. The rest, encourage them to think, encourage them to review it, encourage them to come back to you, encourage them to say, 2 और 3 दिन ले लो, हम तो यही हैं, आप फिर से आके मिल लो. Clarify your thoughts and believe you me, that's the trust factor. Every patient you tell this, कि आप 3 दिन बाद आ जाना, will be there 3 दिन later. Because he says, he didn't push me to have it done.
Correct. You know, and what you just mentioned brought out another very important aspect, Dr. Seth, was that include the patient in the decision making that impacts his health, his life. I think that's a very important aspect.
And by the way, the other thing I would tell you, let's assume that you are convinced on all good science and all your experience that he should have a stent put in. And the patient says to you, but मैं नहीं चाहता, मैं तो दवाइयाँ try करूँगा, and says blankly refuses you. I believe that I should be smiling at him and not saying, अब तुमको जो करना करो. He's made a decision, he's understood me.
Yes.
Shouldn't I help him with that decision and say, yes, मैं ही treat करूँगा आपको. आते रहो, I will make sure that I give you the best treatment. Absolutely. I will make sure कि कहीं भी हमें indicator दिखे, we can have this talk again.
Correct.
But I have to treat him as my patient. Just because he did not agree with my course of action doesn't mean that I wash my hands off him.
Absolutely. I think, you know,
that's the connect.
Patient needs to understand the outcomes of the two options. What are the pros and cons, and he has to be okay to choose one of them and be okay with that outcome which is coming.
Yes, okay with that, but also still consider me a partner in his treatment.
Correct. He's not being left.
He's not being left on his own.
Yes.
And I have a responsibility to partner him in his choices also.
Absolutely. Dr. Seth, India mein there's a disparity. I mean, you know, we know the gap between the number of doctors that we need versus the number of doctors that we have, and of the doctors that we have, experience किसके पास है, किसके पास नहीं है. You are a very busy man. और आपने बात करी of taking time off, having a hobby. How do you keep yourself de-stressed, and how do you take time off for yourself?
You know, if my family was listening to this, before the COVID days, they would say, gosh, the first thing they would say, I wish he'd done this. Now he's sitting there talking about it. Yes, I've had a very busy life, I must say. But I did give time whenever needed, but you're right. But then it also dawns on me to tell others, even by my own example of what I did not do, to realize what I should have done. And therefore, perhaps for a person like me, for me to tell others is far more important, because I did not do it, and I know therefore that wasn't the right thing. That wasn't the right thing, and I did miss out on a lot of things which I shouldn't have missed out. COVID did create realizations. That's why I'm able to talk about it until now, and that's why I'm trying to balance out a lot more. But I'm saying every youngster should balance it out right in the beginning of their lives, and not miss out on what I missed out on, which would be a lot of other things, seeing your children grow up or taking part in their education, should I say, or spending more time with them when they grew up, the family itself, the whole 5, parents. That bonding has to be there as a continuum and not in spurts of life, isn't it? On the other hand, I always say this, that yes, we also owe it to our patients. I mean, I wasn't busy because I was sort of enjoying somewhere else. I was busy because I prided myself that I was with my patients till 2 o'clock in the morning. But I, as a doctor, have always felt, you know, this communication part, I say, even when I still walk out of the hospital at 12 o'clock, and a patient's relative would ask me, आपने procedure तो कर दिया अभी रात के 12 बजे, but इनको खाना घर में क्या देंगे? And you have 2 options. You're tired and exhausted and you've just done a lot of patients, and you say, you have 2 options. Either you say, यही टाइम रह गया पूछने का, मैंने भी खाना नहीं खाया है, ये रात के 12 बज रहे हैं, ये तो मैं आपको कल भी बता सकता हूँ ना. And you wash him off and walk off, कि मैं तो घर जा रहा हूँ. In the same number of words you could say कि ये नहीं दीजिएगा, ये दे दीजिएगा, ये खाना हो जाएगा, उनका इस चीज़ का ख्याल रखिएगा. And you've actually used the same 80 words to either snub him off and tell him कि इस टाइम पे यही रह गया था पूछने का. Versus that. Now what's that? Look at the connect.
Correct.
वो उस दिन पे क्या था, कितना अच्छा डॉक्टर है. ओके. और दूसरा तो डिससेटिस्फाइड, दूसरे को अगर दूसरा आंसर हुआ तो डिससेटिस्फाइड हो गया. नाउ दैट पेशेंट 48 hours later has a complication. 72 hours later has a complication. Goes out of the hospital and has a complication. What would the patient, that connect had gone.
Absolutely.
That connect had gone. Patient आपका connect हुआ ना because of that. Because you really valued the patient, there was empathy, there was everything. वो patient आके will not blame you. डॉक्टर साहब ने तो सब कुछ किया. जो हो गया किस्मत की बात थी. And the other one, you gave her, you brushed her off. उस दिन भी ऐसे थे, पता नहीं क्या कर दिया. So what I'm saying is that empathy, I mean, you cannot, even at middle of the night, patient has to be talked to. Helpless, उसके relatives भी helpless हैं.
बिल्कुल. I think, on that note, we will end this conversation. I'm feeling so guilty of taking so much of your time, but I think, this is such an important conversation, especially on the World Heart Day, because the message of doing the right thing, whether it is for the patient to take care of himself, or for everyone to not become a patient, for everyone around, whether in the corporate world or at home, to be mindful of what to do when there's a need that arises. And third is, as a doctor, the responsibility of doing the right thing for the patient and also for the comfort, mindfulness, and the comfort of the patient and the family. I think this conversation has been really, really meaningful, sir. So thank you so much for taking our time to speak with us on Business World, sir.
Thank you, Mr. Narula. It's been a pleasure speaking to you, and I'm sure it's been a pleasure speaking to the audience as well.
Thank you, sir.